Canadian population. So there are 6 in total, and we are one of them. And actually, we were funded in 2001, so we are actually having a celebration as well. We are celebrating our 10-year anniversary this year. And also, as mentioned earlier, all 5 networks we have, actually if I go back, we have a joint website. So all 6 networks are represented on that link that you see on the screen. So if you had any questions about any of those networks, you can go to that centralized website and look up our individual websites and what we do as a consortium. So what Break Free Alliance does, again, we do a lot of collaborating and partnering. We don't do our work alone. We have over 300 national partners that take part in the work that we do. So we definitely don't do our work alone. We have great partnerships and a lot of experience on the ground that contributes to fulfilling our mission. And so our main goals is that we help assist to build institutional capacity in tobacco control. We assist a lot of states with tobacco control education and have been recently working more on policy issues. And we do disseminate information through conferences. We've hosted 2 conferences in the past, and we're actually hosting one in 2012, and I'll talk a little bit more about that later. And we do have resources on the web that you're able to access as well. We're actually doing our own set of webinars soon, so if you're interested in that, I'll talk a little bit more about that later too. And a little bit about our structure. We do have what's known as a governing body, so we have national organizations represented that help guide the work that Break Free Alliance does. And a lot of representatives are from state and territory tobacco control programs. We do have Salvation Army on board with us and the National Health Care for the Homeless Council. We've recently joined forces with the National Association of Community Health Centers, and we're pleased to say we also have partnership with the Center for Tobacco Research and Intervention, which is housed at the University of Wisconsin. So that has been a new addition to our governing body. So go Wisconsin. So to get into the presentation, bottom line is tobacco and socioeconomic status. This is the single most greatest predictor of tobacco use and low socioeconomic status. And how we define low SES, so our Alliance's working definition, these characteristics are defined as those who have low income, less than 12 years of education, they're medically underserved, unemployed, and or are representing the working poor. Many states do have their own definitions, and there's technically not one correct definition, but this is generally how we defined low SES. I wanted to include some of some Wisconsin data. I'm not sure, hopefully you've all seen this, but if not, this is just out of CDC's BRFIS, and this data is, I think, is the latest data that you can pull is from 2009, but they do segregate their data by income and education level. So this is the first chart here. It may be a little hard to read, but if you look on the left, that's out of those who smoke. If you look at those with the least income, they have the highest percentage of smoking. And I've noted that it's 28% for the 15,000 to 25,000 range. So, and it lowers based on the higher income, the lower that your tobacco use rate is. So, this is not unique to Wisconsin. We see this throughout all the states. And the state data for Wisconsin for the general population is right about 18.8%. So you can see that it's 10% higher for those who have low SES status in the state of Wisconsin. So also this is the next chart, and this is by education. So also to the left, those are out of those who smoke. Those with less than a high school diploma have the highest smoking rates. And again, the higher the education level, the lower the tobacco use, or vice versa. And I wanted to show you some populations and what their respective prevalence rates are. Break Free Alliance works a lot with the homeless population and the incarcerated, and we're getting more involved with those with substance abuse. And we see that these folks have 80 to 95% smoking rates. These are subpopulations of low SES. And the current data for U.S. smoking rate is 17.2%. So, I mean, there's an obvious disparity here, and that's, of course, why we all do the work that we do. So again, just wanted to show you some of the subpopulations that we see have high smoking rates. We see individuals with psychiatric or substance abuse disorder with high smoking rates. Also those with mental illness, patients in addiction treatment. And again, if you remember, the U.S. data for adult tobacco use rate is 17.2%. So again, these are at least twice as high as the general prevalence rate. So again, just listing some more folks, mentally ill, chemically dependent, those living with HIV and AIDS, people experiencing homelessness, those who are uninsured or unemployed. And it really comes down to those who are the haves in our country. They tend to have more incentive not to start smoking, and if they do smoke, they know where to find the resources to quit, and we don't see that with low SES populations. And that leads us really into the social determinants of health. And the World Health Organization, they define social determinants of health as the conditions in which people are born, grow, live, work, and age, including the health system. So these circumstances, they're shaped by the distribution of money and power and resources at global, national, and local levels, which are themselves influenced by policy choices. And as we know, social determinants of health are mostly responsible for health inequities. These are, of course, our unfair and unavoidable differences in health status seen within and between countries, as well as the United States. So these are some of the social determinants of health, and in turn, people suffer more and have the heaviest health burden when it's relating to tobacco use. So, why is this the case, and what's going on in these low-income communities? So we do see that cessation programs are not offered where inside low-income communities and higher-income communities, have these resources available and know of them. And this is not the case in low SES communities. They don't usually, we don't see them accessing the quit line, and they're often not impacted by clean air legislation. There's often loopholes that are not protecting low-income communities. And of course, we see in this picture here explains it all. There's more tobacco advertising in low SES communities, and they're also not always impacted by price increases. And some examples here are, so we see that cessation programs, they're typically not offered where low-income folks go to receive services like shelters or WIC programs, substance abuse treatment programs, food banks, things like that. They have not integrated tobacco education or cessation and even policy into their facilities, so they're just not receiving these services. And again, most are not utilizing the quit line. and often have a hesitancy to call a stranger on the phone, and that's what folks think of when they think of calling the quit line. They're not really sure how it works, and therefore they're a little they're they're not going to utilize it. And of course, tobacco use is still the norm in low SES communities. So this is, they view tobacco use as normal, and if you were to ask them what they feel the U.S. prevalence rate is, it's often much higher than it really is, sitting at 17%. They often say 40, 50, 60%. Their perception is not reality. And the tobacco industry, of course, heavily targets low-income communities, and often advertising is much more obvious in these communities than others. Another slide here is we see that all those who smoke are often food insecure. They still are spending money on purchasing tobacco products, and research from CDC show that it's about 9% of the family income, even though they don't have as much money to purchase food. They still are able to purchase tobacco. And so obviously you've seen the problem, and I'm sure most of you are aware that there are high smoking rates in low SES populations, and so we really want to know, well, this is the case now, what can we do about it? So our first goal is to change the social norm, and we do this through policy. So we want to close current loopholes and ensure any new policies that are written without exemptions from the start, so they benefit all communities in the long run. I know it's hard when we see a policy and we want it pushed, but we really want to make sure that there's no loopholes in there that exempt, for example, bars and casinos, shelters, blue-collar workplaces, and those types of places that usually have exemptions, and we really don't want to see that. We want to make sure that we close those loopholes. Broad-based tobacco control policies have benefited generally the mainstream, so we want to see all communities being benefited by these policies. So you can do that by encouraging organizational policy adoption, and sometimes we go the route of voluntary policy adoption. So when you're working with blue-collar workforces or like a workforce development programs and places that they have the ability to change their policy, we want to encourage them to adopt voluntary tobacco-free policies, and target your work at work sites that employ low SES workers or serve low SES folks. And here are some partnership examples. So if anyone on the phone is looking and they're not sure exactly where to start or who to develop partnerships with, here are some examples. We encourage folks to work with Walmart or other large retailers, Salvation Army. I'm sure you guys are already working with, but they're great to work with. Bars and casinos, community action programs. I'm not sure if you guys have those in Wisconsin, but they are nationwide, I believe. Daycare centers, parks, playgrounds, your correctional facilities, workforce development settings. That's a Job Corps, Conservation Corps, and those are for like the 18 to 24 young adult population. Construction sites, bus stations, veterans services, and multi-unit housing. So if you can think if there are any of these that are near you or that you're interested in working with, we encourage you to work with these folks. And a little later, I'll go over an example of what we did at the Sacramento Job Corps. We worked with them on some policy and cessation, so I'll talk a little bit about that.